Kwan. I direct the Accords Education Program. And this seminar here today is part of our seminar series in behavioral science and healthcare. And many of you probably have heard from Brian Ford, who's our program coordinator. Without you, you would not be here or have lunch today. So thank you, Brian. If you haven't already, please sign in. I believe there's a sign-in sheet going around, and then there is an evaluation. So please fill out the evaluation before you go. I'm supposed to remind you that strongly disagree are the ones on the left. So upcoming seminars in our behavioral science and healthcare series are, we are very excited to have Gretchen Chapman from Carnegie Mellon University in Pittsburgh coming to talk about leveraging automaticity for health behavior change in January. And then we're going to be moving beyond our individual level change strategies to practice, provider, organizational, and policy level change in the spring. So we have a talk on implementation strategies from some local implementation scientists, a visitor to come talk about multi-level model of change capacity in health systems and organizations, and then a distinguished lecturer from Dr. Jim Salas on behavioral medicine and policy change in April. We also have a series on the science of patient-centered decisions. Where's Laura? Laura's right here. She gave a talk, a very well-attended talk for science of patient-centered decisions last month or earlier this month. I'm trying to make December over too soon. So Dr. Chapman's also going to be, we're advertising her talk through that series as well. And then we have several shared decision making in practice talks coming in the spring as well. So please join us for any and all. Today, we recorded seminars for any that you've missed can be found on our Accords website, or you can follow this little link there. And then we're always available for consultation around additional educational opportunities and resources within Accords. Also on our website, there's a button to request a consultation. There you go. Okay. So today we are delighted to have Dr. Kevin Masters from the downtown University of Colorado Denver campus. He's a professor of psychology and program director for their clinical health psychology program there. How many of you have been to previous talks in this seminar series? Good, almost everyone. And so you've learned a little bit about what is theory, how do you apply it in health and healthcare, how do you test it, how do you design interventions. And so Dr. Masters is going to talk to us today about building theory-based health behavior change interventions. This is sort of a parallel talk to what Dr. Lieberman did late last month. And he's going to be talking about a particular project. We know you all love examples, so he's going to be sharing an example from his own work. He is a clinical psychologist and a leader in the fields of health psychology and behavioral medicine. He's the editor-in-chief of the Annals of Behavioral Medicine journal and former editor of the Journal of Behavioral Medicine. He studies cardiovascular processes and disease from the perspective of behavioral medicine, as well as the relationship among spirituality, religiousness, and health. And he's currently involved in research examining religious practices, life meaning, and cardiovascular stress reactivity in the lab. I was just talking about this with Anawara yesterday. And how meaning and purpose may increase adherence to healthy behavior regimens. So with that, thank you so much, Dr. Masters. I'll turn it over to you. I think Brian will help you.
All right, great. Well, thanks a lot. Let's see. That wouldn't be my first slide. No. I'm sorry I've missed some of the other talks in this series. I've been to a few of them. I wasn't able to get to Lars, and I wasn't able to get to the other one recently, which is the fault of traveling too much. So hopefully what I have to say won't be completely redundant with what you've heard in some of the previous talks. If it is, well, you still got food out of the whole thing, so you can't really complain too much. Are we ready to go? Oh, okay. right, great. So you can see the title of my talk there, and I should point out that we've had some funding and support from the Office of Research Services here at the university, and I'm also on a R01 grant with Vicki Catanacci, and that is actually part of the Science of Behavior Change initiative that I will be referring to a little bit through this talk. And I need to, good? Good. I need to thank my colleagues who worked with me on this, Stephanie Hooker, Jenna Lee Wooldridge, and Kayla Ross. Actually, at the time, they were students, but now they're colleagues. So that's always a good thing from my perspective and from theirs, I'm sure. And also the Health and Wellness Center, where we did quite a bit of this work. And finally, I have no conflicts of interest, though. If you'd like to tempt me with one, I'd be happy to see if I could get one. One of these days, I want to have a really juicy conflict of interest to report, you know. Well, this talk and the idea for this talk really came about as a result of a really practical problem. We were trying to figure out how to increase activity, physical activity. And for reasons that I'll go into in a little bit, we were quite aware of the fact that although theories exist, they're rarely actually tested in intervention studies. And so we said, well, we want to build a theory-based intervention around increasing physical activity. And then it was sort of interesting to think, well, how do we do that? I mean, how do we take our theory that makes a lot of sense when we read about it and we can see it in our heads and it's all there, and how do we take that and make it into something that we do, something that we can say with some confidence, I did this and this then happened and this was in accord with the theory that we had developed. And so we started really looking at this question of how do you operationalize theory into an intervention from the very outset, from the get-go. Not, we know how to measure things down the road, but by then a lot of money has been expended, and if it's not working very well, you've maybe wasted a lot of time. What about on the front end of it? How can we design these interventions in a way that's more theory-based? And I'll admit that I was influenced by some of my European colleagues. In the States, we talk much less about theory than they do in Europe. In Europe, they talk a lot more about theory. And in fact, I was submitting a manuscript to a journal, and the editor, who is somebody I know, I'd sent him an email ahead of time, and I said, hey, do you think this manuscript would be of interest in your journal? And he said, well, if it's theory-based, it might be, which is not a comment you get much from folks in the States. But for a number of reasons, it occurred to me that maybe that was the way to go with some of this. Now, I should back up a little bit and say, it's no surprise to you that I'm a little older, and I'm also very cheap when it comes to speaking. So if you're old enough and cheap enough, you can get invited to speak at lots of places. And typically, when I do that, I don't get all that nervous because I've given lots of talks. This talk's different. This morning I got up and I thought, well, I'm kind of nervous about giving this talk. I don't know why I'm nervous about this talk, really. And I thought, well, maybe it's because Laura might be there, you know, because like she's smart and, you know, understands all this stuff. No judging? Yeah, but I heard that there's evaluations. And then I also heard that we might not know which side of the evaluation strongly disagrees on. So I'm going to interpret this in a way that works best for me later. And it occurred to me that the reason I'm a little nervous are twofold. One is I don't really know what you guys know about these topics. So it might be that the first half of this talk, for example, is something you already know about. And if that's the case, I invite you to, you know, enjoy your lunch, take a power nap. If you could keep your eyes open during the nap, that would be helpful for me personally. Maybe pretend to be noticing. But it could be that the first part's review. I don't know. It also might not be review. And if it's not review, it gets a little wonky. And then the last half of the talk is where we'll get into some of the newer stuff that we tried to do with our particular intervention. There's also a paper that came out of this that was published in Annals of Behavioral Medicine. And so if I go too fast or things aren't all that clear, I will refer you at the end. I'll put the slide up and I'll refer you to the paper, which is easier to read in a way, and you can kind of flow with it, and I think that will suffice. All right, so there's some learning objectives for the presentation today to be able to map the processes of psychological test development onto theoretically based health behavior change intervention development. And we'll get into that more in terms of what that means, obviously, later. To be able to describe theoretical validity, as it pertains to behavior change interventions and why it's important and how it can be measured. And then finally, to be able to discuss the nature of mechanisms or processes and their role in behavior change interventions. In terms of the overview of what we're going to be doing, where I'm going to introduce the problem as I see it, or problems really, plural, an introduction to theory, the black box of moderators, mediators, mechanisms, and processes, and then finally, the approach that we developed around behavioral intervention development. My personal goals for this, though, really are not so much that you come out of this saying, now, what was step 3 again? I want to make sure I've got step 3 right. If you get to that level of thinking about it, you're overthinking it. What I'm wanting you to come out of this is really with a way of thinking about theory-based intervention development, a way of thinking about how do I operationalize what I want to do in a way that's consistent with the theory that I'm basing it upon. There could be any number of ways of doing this. Even since I put the slides together the other day, I thought of some things I would do differently. And this is, I don't know that anybody else has written it up this way. It's new, and it's certainly wrong in many aspects. But what it's probably not wrong about is that we need to be thinking about and ostensibly, not ostensibly, what's the word I'm looking for here? Explicitly putting theory development at the front, theory inclusion at the front of our development of our interventions. So if you get caught up in the details, you'll kind of miss the point. I'd be very happy if you bumped into me 6 months or a year from now, and number one, you remembered that I even gave a talk for good reasons. And number two, you said, gee, I can't remember what you said, except we've been building this intervention and we've been really trying to make sure we've got theory in it from the beginning. If you said that to me, I'd say, great, whatever you're doing, it's way better than what's mostly been done to this point. Okay, let's talk about the problem a little bit in general. And this comes straight from the Science of Behavior Change Initiative. And so I wanted to highlight that. I know that some of you, I know Danielle and some of you are aware of that initiative. It's the National Institutes of Health through the Common Fund has put out this, I don't know what you would call it, program, I suppose, focusing on behavior change. And it's kind of in the background in terms of this talk would have been an interesting talk, I think, a couple of years ago, but you might not have known where to fund some of the initial research from this talk. Now there's actually a place in the NIH that's looking to fund projects that would be very similar to what we're talking about here. But real quick, what's the problem? I probably don't have to convince this crowd that unhealthy behaviors contribute to negative health outcomes, and there's a whole list of unhealthy behaviors that you are familiar with. Depending on your take on this, somewhere between 40 to 60% of the risk associated with preventable premature deaths is related to these behaviors. You can get numbers higher than that, lower. You can play with the math. At any rate, it's important. And the other thing that we've found out is that changing behavior in the short term is really not all that difficult. It's actually not real simple, but you can do it. You can get people to change in the short term. The problem that we've run into in behavior change is changing behavior over the long term. That seems to be a much more difficult proposition. So what would make behavior change interventions more potent and lasting? If what we've got now are interventions that change primarily in the short term, what could we do to get them to be more effective? Well, possibly one idea might be to utilize theory in intervention development. Now, you might say, well, we do use theory. Everyone uses theory. In fact, everyone uses social cognitive theory. I had an interesting experience a couple years ago. I was meeting with a physician friend. We were talking about a behavior change intervention. And he said, well, I wanted to talk with you guys because they want us to put something in about theory. What should I say? Should I just say social cognitive theory? Because if I say that, they won't question it. And that was an interesting point of view. It's kind of true. If you say you use social cognitive theory, you can make about anything fit under it, or not even try to make it fit under it. Just say you use social cognitive theory, and reviewers generally will let it go. Well, we're thinking you need to do a little more than that if you're going to actually be utilizing theory in intervention development. But that point brings us to another problem. That's why I said this should be the problems, and that is the theory intervention gap. Only 22.5% of 235 behavior change implementation studies explicitly identified a theory. That's just identified. That's just said there was a theory involved here without necessarily any demonstration that they actually used the theory. More recently, 56% of physical activity interventions reported a theoretical base, so that sounds a bit better. But 90% of these studies did not report links between the behavior change techniques and the specific theoretical constructs. So whether or not they actually operationalize or activated in a sense, the theory into the behavior change, we don't really have much way of knowing. Well, why would we even want to use a theory? I mean, is there any evidence that an intervention based on theory is better than one not based on theory? And the answer is not exactly. I'm not exactly sure that. There's been a little bit more evidence in the last year or so, but it's really not very strong. And why is that the case? Well, perhaps it's just not stronger. That could be. But the real issue at this point in time is the theory is often so poorly applied that we don't even know if the theory has been tested. I mentioned this Mickey and Prestwich article where 10% of the studies looked at behavior change techniques, but only 9% of those reported that they actually measured all the constructs that were involved in the theory with the behavior change techniques. So why use theory? Well, one reason I would argue is we don't know if theory is better, so maybe we should test it. But another reason I would say we should use theory is you can't really escape using a theory. You have some kind of theory. There is some reason that you're doing what you're doing. It may not be explicit, it may not be systematic, but you chose to do something rather than something else when you set up your intervention. So there's some reason that you're doing what you're doing. It could be implicit, unsystematic, folksy, and I don't mean that to be negative, by the way. I think people can come up with really good ideas. But wouldn't it be better to be explicit and systematic about it if what you're doing is something that you hope can be replicated not only in the scientific world, but if it's successful, could actually be replicated in the practice world? Now, developing a behavior change theory is a little different. How many of you in the room are physicians? Just curious to see. So we have a few of you. Well, that changes my talk a lot right there, actually. If you're designing a new drug to treat an illness, you probably don't have any, you're a biochemist at a pharma company or whatever. You don't live your life around that new drug. You don't have personal experience day to day with it. You understand the chemistry and the molecules and all of this sort of thing. But with behavior change, it's an interesting ballgame because all of us have changed behavior in some way. We've seen instances of behavior changing. We've changed our own. We've seen other people change behavior. So to some extent, we come to the table with ideas about behavior change that are sort of already baked into how we think. And I'm not suggesting that those are necessarily inferior to systematic theories that have been developed. In fact, if you look at the theories and then you get to know the theoretician, you find out that you ever heard that phrase, me search? You do, instead of research, you do me search. You often find out that, well, it's pretty obvious where that theory came from. So I'm not suggesting that our own implicit theories are necessarily worse. What I am suggesting, though, is that as long as they stay implicit, they'll be very difficult for us to test, and they'll be very difficult for us to figure out any way of communicating with somebody else about them if we want to make them happen in a repeated way. And there are some benefits from using theory, It can facilitate development through identifying the key constructs to target for the behavior change, and we will get into this a little more thoroughly in a few minutes. It's a way to support evidence. One of the things I'm suggesting is that we don't have accumulative evidence because we haven't really tested the theories. One of the problems that people, when I've talked with people about theories and behavior change, they say, well, there's a lot of theories. In fact, I think Mickey, when she did her review, found 83 theories of behavior change. How do you pick one? That is a problem, and it's a problem that I'm not going to address. So we're going to beg the question on that one today. But I would say this, if we actually really tested those, we might not still have 83. You know, we might be able to weed out some of them. And by identifying mechanisms of change, the theories might aid us in determining why an intervention was or was not successful, what changes to make to it, and so forth. I'm going to just skip this slide because I think you guys have already know what basically a theory is. No point in reading that slide to you. We can come back to it if somebody would like to know more. But what do they do for us? What do theories do for us? Well, they help us open up the black box. We have something that happens. Like, why don't I just go to the next slide? We have something that happens, an outcome, that's C. We have, in this case, some kind of behavior change intervention that we did, call that A. And then in the middle, we have these things, this black box. So we did something happened, but why did it happen? What were the processes or the mechanisms which facilitated that change as a result of A to C? Now, at this point, I'm going to talk about mediators, moderators, mechanisms, and all that business. How many of you would say, I'm just curious, it might help me know how much time you spend on this. How many of you would say, I'm very comfortable with those terms. I know what a mediator is. I know what a mechanism is. I know what a moderator is. Could we just skip it? How many of you would say you're in that position? Okay, a few of you, some of you confidently so. Some like, is there going to be a quiz? So I'm not so confidently so on that. So I tell you what, I'm going to try to strike a middle ground and go through it at a sort of accelerated pace, but we can come back if people have questions. For our purposes, I'm going to start with the mediator, but for our purposes today, it's probably the least important of these constructs that we're going to be talking about. So, and this terminology, by the way, comes from a couple of seminal articles by Kramer in Archives of General Psychiatry and by Kasdan in Annual Review of Clinical Psychology, I believe it was. It might have just been Annual Review of Psychology. The mediator, an intervening variable that may account, and I put in the parentheses, statistically for the relationship between an independent variable and a dependent variable. Technically, a mediator may or may not be a mechanism. A mechanism will be a mediator, but a mediator may or may not be a mechanism. Here's an analogy, a risk factor versus a cause of disease. Well, a risk factor might predict the disease, but it may not be the cause of the disease, right? It may be related to something else that's the actual cause of the disease. So we would say the risk factor isn't actually the mechanism. Now you can kind of forget mediator because we're not really going to use that term much through the rest of the talk. But let's talk about mechanism. And I've also put in parentheses this word process here, and I'll tell you why in just a second. A mechanism is in fact the basis for the effect. So the mechanism or the process is the event that we believe is responsible for the change. This is the link between what we did and what then happened, or what caused the change, why the change came about. Now, mechanism is the term that's used. The Science of Behavior Change Initiative only uses the term mechanism. Mechanism is the term that's used. I don't like the term mechanism. I like it just fine for biological basis of effects. So if we're talking about a mechanism at a biological level, I'm pretty comfortable with calling that a mechanism. I'm less comfortable in the psychological world calling these things mechanisms, because mechanisms sound quite domino-ish to me, quite mechanical, quite determined. And I've worked just enough with people clinically to figure out that it seems like there are more processes. There's these processes, things that happen, but they're not quite mechanisms. I don't know if that sense or that flavor is at all of interest to you. I don't think I'll be successful in starting a revolution and changing the terminology, but I wish I could. Because I think if we thought of it more in terms of processes, I think we would think more in line with the actual phenomena that we are observing and with the observation of our study, which is human beings. And I think we would be, I think ultimately would be more accurate and probably more effective. But we can go into that later. But so you heard it here first. If it becomes a thing, you can say we heard it here first, we were onto it. If it doesn't become a thing, then just use mechanisms, but always feel a little guilty when you're talking about it in a behavioral sense and think processes in your mind. While these mechanisms or processes do have to occur during or after the intervention, they have to come between what is mediated and the outcome, and they have to answer the question of why or how the intervention worked. By the way, here's another pet peeve of mine. Somebody will say, that must have been a moderator because we looked at an interaction. We tested an interaction. We haven't talked about moderators yet, but moderators are typically looked at through interactive effects. No, that's not the case. You decided to test something and you put it into an interaction. Whether it's a moderator or mediator or not depends on all sorts of other characteristics. The numbers are always dumb. They never know why you put them into the formula you put them into, right? So well, I'll be in a thesis defense meeting and they'll say, well, this is a mediator because we tested it this way. No, you tested it that way because you thought it was a mediator, right? You can test it that way and you can get data that would suggest it might be a mediator, and it may well not be a mediator because it doesn't meet the other criteria. Anyway, that's just a little pet peeve of mine. I think you're always much better off going at these things conceptually first and then have the statistics be appropriate for the conceptualization that you've made, and then see if it happens, if you get what you're looking for. Didn't realize I had so many pet peeves built into this talk. It wasn't like this when I was practicing, I promise. It was really nice and friendly. And then a moderator. A moderator is a characteristic that influences the direction or magnitude of the relationship between the IV and the DV. So, for example, if this effect is different for males than females, then you would have sex as a moderator. For something to be a moderator, though, it needs to be at baseline or a pre-randomization characteristic in an RCT, exists or occurs before the intervention, and answers who or under what circumstances is a differential effect found. Now, let me give you an example. We have been doing a pilot study that's now turned into being a multi-site RCT, looking at an intervention, a lifestyle intervention to treat individuals with metabolic syndrome. And while we were doing so mindfulness, something probably many of you are somewhat familiar with at least, mindfulness is a component of this lifestyle intervention. The intervention goes on for, it's 3 months every week, 3 more months every other week. And while we were doing the intervention, there's this mindfulness piece that's kind of integrated into each week of the intervention. And it was kind of interesting to watch. So we had men and women in the group. And this is just an observational, I mean, we don't have any data on this. The people that designed the intervention, unfortunately, didn't follow my rules, and we're not testing any of the things we ought to be testing. But as I watched and did the intervention with these folks, I was one of the interventionists. It seemed like the men in the group were not really digging the mindfulness piece. It just didn't seem to fit for them. I can tell you for sure, by the way, they weren't digging the dancing piece. But that's another whole topic. And so it occurred to me that we have some kind of a gender issue here around mindfulness, and that now that we're going to the multi-site trial, maybe we need to package that a little differently. Maybe we can get at those same constructs, but not use the terminology that we use. It really did seem like the men in the group, by and large, kind of tuned out on that. Well, if that's true, if I'm right about that, then it's possible that we have a moderator of our intervention with that particular group. Let me give you another example. There's some interesting research, some of the stuff I'm familiar with, where we find that greater religious service attendance predicts decreased mortality. Now, the question that you might have is, why? Why would that be the case? And in other words, what you're really asking is, what are the mechanisms, or better stated, processes, that could account for this relationship? Now, you might come up with a lot of ideas, right? It might be that you get social support from going there. Of course, one reason might be that healthier people are actually able to go. That's been controlled in the research and so forth. But you could come up with a lot of possible ideas about why that might be the case. Maybe it's certain beliefs, maybe it's optimism, maybe it's social support, et cetera. You could go on and on with that. If we found what that was, what that thing was, we would then be finding what the process is to account for this relationship. By the way, there are moderators of this relationship as well. The difference for African Americans who are regular church attenders in terms of life expectancy is about 14 years on average, which is pretty remarkable. That's much more than it is for white Americans. Let's look at another example from the Enriched study. So Enriched was a study where we were trying to intervene for heart disease. It was a multi-site randomized trial, looked at depression and lack of, so they were aware that depression and lack of social support predict the recurrence of heart disease. So the idea was to then target or intervene to reduce depression and increase social support and see if in fact that would affect the primary outcomes of survival and reinfarction. So if we're looking at it, and we're looking in terms of our designs, intervention versus control, and we're hoping to affect survival and reinfarction. And to take just one of the instances of this, we wonder, well, what's the process? How are we going to do that? How is this behavior change intervention going to ultimately affect survival? Well, in this particular case, at least one of the mechanisms they were looking at was to decrease depression. So the idea was, if we decrease depression, because we know that depression is a risk for reinfarction, if we decrease depression, then perhaps we will affect survival in a positive way, and reinfarction, have lower rates of reinfarction. But now, if you're actually designing the intervention to do this, you can't really wave a magic wand and say, okay, your depression is less. And you have to do something to get the depression to change, right? And so what would those somethings be? So I've never actually seen this model. I've never actually seen anybody diagram it like this, and there's probably a reason that they don't do that, but it seemed like it worked pretty well for me, because in a sense, if you're going to change depression, well, I'm a practical guy. How do I do it? I mean, how do I get there? And you could pick a lot of possibilities. You could do medication, you could try to change cognitions, you could do behavioral activation. There might be a number of ways that you could go about trying to do this. But in any event, these would really be the mechanisms by which you're trying to change this mechanism, by which you're trying to change this outcome, right? Does that make sense? Now, I won't even go into that. Somebody will bring it up later, we'll talk. But you can see that it can get to be somewhat complex. Now, by the way, let's talk about what actually happened in Enriched. Well, what happened in Enriched is there was no difference between, for the overall sample, there was no difference between the intervention group and the control group. So that would make it a failed trial, right? Does that make it a failed trial? Well, what would make it a failed trial? If a finding of no difference doesn't make it a failed trial, what would make it a failed trial? Well, I would argue that what would make it a failed trial is if you couldn't know why there was no difference, right? If you found it, and similarly, if you find that there is a difference, but you don't know why you found a difference, it's not a failed trial, but it's not an entirely clear trial. Well, in this case, what happened was both the control group and the intervention group decreased depression rather significantly. There was very little difference between them. So in that sense now, we might have a failed trial, right? Because we never could really test our hypothesis. We don't know if there's a difference because of this mechanism, because in fact the mechanism changed almost the same for both interventions. So we can't really unpack what happened there and find any kind of causal relationship between these arrows. Now, the science of behavior change has really kind of brought these issues to the forefront. It's maybe the first time NIH has really emphasized or specified these particular ideas. And this is taken straight from the Science of Behavior Change's webpage. I thought you might want to see what they're saying. The Science of Behavior Change program aims to implement a mechanisms-focused experimental medicine approach. Now, I don't know why they call it experimental medicine approach. See, here's the thing you need to know about behavioral scientists, and I guess many of you are behavioral scientists, so you might want to take issue with me on this, but you know, my son always jokes with me. He calls me, Dr. Masters. And he doesn't really say it respectfully. It's and he always reminds me of the episode of The Simpsons where there was an emergency on the airplane And the guy says, I'm a doctor. And the flight attendant says, MD or PhD? And he says, oh, PhD. And sits back down. And so we're not real doctors, and we kind of know we're not real doctors. And so we have this complex, and the science of behavior change has decided to actually, put that complex into writing for all the world to see. And so they call it experimental medicine approach, okay, to behavior change research. And this experimental medicine approach involves identifying an intervention target. Well, that's really a mechanism, what they're talking about there. Developing assays, and then they have to put in parentheses measures. Now, if you have to put in parentheses, right? You see where I'm going with this? Why in the world would you call it an assay? I looked up assay. I can't find any definition of assay that comes anywhere close to talking about what they're talking about here, but we have a complex. So we put that in. I have the complex too, don't get me wrong. So, okay, so we make some assays / measures to permit verification of the target. Okay, measure the mechanisms, what they could have said. We engage the target through experimentation or intervention, and then we test the degree to which the target engagement produces the desired behavior change. Without all that sort of mumbo jumbo in there, it's actually a really good statement of a real nice way to go about doing research, although it's been sort of obfuscated quite a bit. All right. So last week I was with this group called, or a couple weeks ago, Behavioral Medicine Research Council, and this is a group of people who are, some of the big honchos in behavioral medicine. Now I got to go not because I'm a big honcho, but because I'm a journal editor, and it's kind of like being a rich person. When you're a journal editor, you get invited by people to places, and so I got invited to this thing, and we had this long discussion about mediators. About mechanisms and when should we be measuring them and should we be measuring them and aren't they too difficult to measure and won't they be overly burdensome and won't we just run all of our research subjects out, they'll screaming and running away from us, and then other people were arguing that we should, and show me one time that there's been a change as a result of a mechanism study. To which I said, is that an argument? I mean, that's an argument for making the changes, not for the fact that they haven't been done. We ought to do what we say we should do. Anyway, there was this big long debate over the whole thing, and it occurred to me that a lot of the debate could be solved very simply if you just based your intervention on theory. Then you would know what the key mechanisms were to study. You wouldn't have to fish for every mechanism that might possibly exist. You could target those important ones, and you could answer your question based on those important ones. So then I asked myself, does the science of behavior change mention theory? And not really so much. I talk about the mechanisms. Well, where do the mechanisms come from? I mean, how do you have this idea that this thing is or is not a mechanism if you don't have a theory? All right, that's way too long. I'm falling way, way, way behind. So we're going to, I think, just skip some of this stuff because you probably already figured that out. If the world works as we desire, what will happen in terms of these behavior change interventions? Well, we'll find that our theoretically driven intervention will demonstrate improved outcomes, behavior changes relative to our comparison. We'll find that the intervention differentially influences these mechanisms or processes in ways that were predicted by the theory. In other words, the processes should behave the way the theory says they should. And we'll find that these processes and mechanisms predict the outcomes, that they are in fact potent. So this would be great. This would be best case scenario if it all worked out just like this. So as we were trying to design our intervention, it occurred to us that there might be lessons in the world of psychological test construction that could carry over into the world of theoretically based behavior change construction. So I'm just going to put these up quickly. These are the basic steps that are reasonably agreed upon, as much as psychologists agree on anything. There's reasonably agreed upon steps for how you develop a psychological test of something. You start with a definition of what it is that you're trying to measure. Some of you are probably familiar with Cronbach and Neal's classic article many years ago talking about the nomological network. So if we measure this thing in the right way, how will this measure relate to other measures, similar, dissimilar, and so forth? We'll have to generate some test items. We'll have to have concern when we do that we have construct validity. so that we're covering the whole the whole area of this construct in appropriate amounts. We'll test the measure. We'll probably do some kind of factor analysis. We will look for reliability. Does the measure hold together? What about over time? Does it do what we think it should over time? And validity, and then we'll do some final testing. So we decided that we would do this for our intervention. Now, I was going to have us build a test for depression. I think, because I'm hopelessly behind, I think we'll have to make that more of a mental exercise for you to practice when you go home. But think about it. If you were going to build a test for depression and you were going to use these basic steps, what would you do? And if you think it through, what you'll find, I think, is that those steps are going to be very similar to what we're proposing in terms of how to build a behavior change intervention. So let's talk about those steps real quick. For a behavior change intervention, well, the first thing we're suggesting is that you have a clear and explicit theory definition, similar to the definition of the construct that you had in the psychological test. The identification of the key constructs of the behavior change theory be made explicit, and this, of course, will constitute what we call the intervention nomological network. This theory would say that if I do certain things, certain other things will happen because of this reason, right? Because of these mechanisms. So what are those theoretically? We ought to be able to map that out while we're at the developmental stage. And then we'll construct the intervention to try to operationalize the mapping that we've just undertaken. We'll do some initial testing. Does it work like we think it will work? At this point, we're not really talking about outcome testing. I mean, I can never, in my heart of hearts, I can never do a behavior change type study without looking at the outcomes. Because I think even at the very beginning, if it doesn't look like it's affecting the outcomes at all, maybe I should know that. But, you know, people argue about this. Some people say, oh, no, you shouldn't, don't care about outcomes at the beginning. No. Really? You don't cheat and kind of just see, is anything happening there? But the emphasis is really on the theoretical validity at that point. Are the mechanisms themselves being affected? And then finally, we'll go with the more formal tests. So let's just kind of walk through this. But here is the definition that I'm using for a theoretically based intervention. Deliberately designing the intervention to target the theoretically derived mechanisms or processes of change is really the essence of a theory-based intervention. If you're not doing that, then whatever you're doing might be really good and it might actually work, but it wouldn't be theory-based. Just 1 second. Okay, this is a really busy figure, but it's in the article. If you look up the article, you can get all this. We're going to break it down real quickly. So step one is to choose the theory. And I suggested that formal theories are important, but brainstorming and implicit theories are also important. But somehow or other, at the end of all that process, you need to have something that's the theory that you're going with for your intervention. Now, in our study, I don't have time to go through all this exactly, but in our study, we basically did two things. We had an initial interview with people to find out what was meaningful to them in their life and how they went about their day and when they might be able to be more active. And then we designed a smartphone application that delivered these messages at certain times, and we'll go into that in just a little bit. The theory that we used was really this sort of an amalgamation of self-determination theory, existential theory focusing on meaning and purpose, and then motivational interviewing, not so much as a theory, but as one of the techniques of operationalizing the other aspects of the theory because it's philosophically consistent with what we were trying to do. By the way, we were into this whole thing with the idea of, can you change behavior over the long run? So that's why we were trying to do something different. Social cognitive theory is good for what it does, but so far we haven't really seen these long-term changes. And so we were trying to think, is there some other way of thinking about this for theories that are currently available that we could work on that might have some longer-term impact? And I can tell you why we thought that later if you like. All right, step two is identify and characterize the key concepts and expected relations that we have inside of our theory. So what are those theoretical mechanisms? Do we have adequate sampling of them in our intervention? And have we designed this, what I call the theoretical intervention nomological network? Do we have an idea for how these interventions will affect the mechanisms that will affect the behavior change? And have we thought that through in terms of the intervention? So in self-determination theory, we really identified three core components: autonomy, relatedness, and competence. So as we started building our intervention, we wanted to figure ways that this intervention would, in fact, impact a person's sense of autonomy, their relatedness, and their competence. Similarly, with meaning and purpose, we developed this idea of meaning salience. Can you become aware of meaning in your daily life rather than only at certain times of year or certain big events? And then using motivational interviewing as part of the technique for it. Then in step 3, we will look at choosing the mode of delivery, matching the mechanisms and the intervention techniques. And one of the important pieces of all this is, while we're going through this and we're working through this step-by-step process ourselves, we want to have some reason to believe that what we're doing would be agreed upon by outsiders who would look at it. And so one of the things we did here was have experts test what we call the theory intervention fidelity, do a theory intervention fidelity test, and I'll show you just really briefly what that is. Then the other thing in any intervention is to create a good intervention manual. But if it's going to be a theoretically driven intervention, you really need to make sure that the theoretical basis of the intervention is included in the manual. When you work with real people, different things happen. You're going to have to adapt on the fly. And we want to make sure that people using the intervention are able to do that. Let's see here. I'm going to go through this kind of quickly. So here's part of what we did. What's the component? Well, one of the components was this individual interview that we did at the start. What were we targeting in that interview? We were targeting meaning and purpose. We wanted to explore what the individuals do, or what the individuals believe is valuable and meaningful to them, because one of the core components of this intervention is going to be the idea of making meaning more salient in their life. And if we do that, will we be able to move the needle a little bit on, in this case, we were looking at physical activity. Individually tailored messages with reference to significant others. That was targeting the self-determination theory idea of relatedness and relating this activity, this physical activity, with important people in the individual's lives. If we go down to the last one, a text message delivered with affirmation and positive reinforcement for what the purpose had done for their activity. We saw that as mapping onto competence in self-determination theory and reflecting their progress and so forth. So this is kind of the idea of mapping these interventions together. The interventional component, what you're doing with a targeted construct that it's affecting. And keep in mind, this is all at the developmental stage of the intervention, not later. And then building some validity checks into the interventions. We asked experts to rate these aspects of our intervention. We gave them this thing we called the theory intervention fidelity to treatment test, or the TIFT. That's because we had a few TIFs while we were trying to develop this thing, so we thought that was appropriate. For example, with our experts, we said to them, we're doing an initial interview with the interventionist to explore what participants find as valuable and meaningful to them. Please rate which of these constructs do you think we're targeting. Now, you could make this list. There could be a lot of things you could put here. In our mind, this is going to target meaning and purpose, primarily. But it's going to probably also target maybe social support, maybe relatedness. I'm not, but we wanted to see, would they agree with us, at least in terms of the primary component? And then those of us on the intervention team actually also did our own ratings. And I'll show you, I think I have this one on a later slide, how the two compared. Then fourth comes the initial testing and revision of the intervention, with an emphasis again on the theoretical validity of the intervention. So we want to gather feedback from the target population, do some pilot testing, looking at some of those usual things you look at for acceptability and feasibility. Then we wanted to have participants assess with us the intervention fidelity, the PTIF, as we called it, and make iterative changes as needed. So in this case, what we did was we brought in focus groups and we told them what we planned to do. Just talk to them about our intervention, get their feedback. And we're looking for, do they think this intervention is going to do what we think it's going to do? Now, we weren't asking them, we have a theory and does it matter? We weren't asking them that. We were listening for their responses to see if those did, in fact, map on to our theory. And then we did some pilot testing where we actually had a group use the intervention for 2 weeks. And with them, we actually gave them this thing we called the P-tip, and I'll show you what that is in just a minute. So here's the P-tip for individuals who had actually engaged with the intervention. So we asked them, overall, I felt like this program was respectful of my right to make my own decisions. Now, we didn't put the autonomy, but that's what we're asking about. And so we would ask them to rate this on a scale, I think it was 0 to 10, if I remember right. Or, for example, we asked them, the program adapted to my current level of confidence in my ability to be physically active. So we were targeting competence with that. So we're asking these people, essentially, did this thing target, did it feel like, did you notice this when you were doing this intervention? Were these targets hit for you, so to speak? Now, when we talked with the folks we had the focus groups with them, so we had them fill out these questionnaires and we also did a focus group. We asked them, all the stuff you ask in a focus group. And one of the things that they said in the focus group was they wanted more accountability in the intervention. Now, accountability is a, common technique in behavior change interventions. But that really wasn't part of our theory. Self-determination theory is not really about being accountable to other people. Meaning and purpose was really about individual meaning and purpose. Motivational interviewing is not a sort of authoritarian accountable intervention. Accountability didn't really fit, so we had an interesting decision to make. What would we do with accountability? The focus group said accountability would help. I think it would be better if there was an accountability component to it. But accountability didn't really fit with our theory. So what we decided we should do if we're going to have a theory-based intervention was stick with the theory. Now, there were lots of other ideas that the focus group had that fit pretty well with our theory that we hadn't thought about. Personalization, certainly nothing wrong with that, fit very well with our ideas. They really liked the idea that if the message came to them and it identified the particular individuals that we were talking about in their world and so forth. So, there can be decisions to be made along the way if you're going to stick with a theory-based intervention. And then we had some professionals review the intervention. We had our own team do some ratings. Then we had the group of experts come in. I'll just show you. Here's one of them. This is, which one is this? This is from the MI style. Oh, this is the idea of developing. This is a developing discrepancy intervention. So when we did the interview, people would say, I really value this, but I don't do it that much, and so forth. And so in motivational interviewing, you do this thing called develop discrepancy, where you highlight the two sides of this dilemma. So our team, we asked them, we did that 0 to 10 rating. Our team thought this was full on developing discrepancy, a bit of meaning and purpose, maybe a little less of autonomy, and really had nothing to do with self-efficacy. Our experts that we had rated, rank ordered the same as we did, but slightly different in terms of their ratings. And they thought there was a fairly good dose of self-efficacy. I think there's probably a fairly good dose of self-efficacy in everything. Can we just stipulate that, among ourselves, that if you believe you can do something, you're actually going to be more likely to do that something. Can we just settle it for all time and we don't have to do another correlational study on self-efficacy? Now, what do these numbers mean? It's a good criticism if you're doing a psychometric-based development of something. I haven't a clue what they mean, really. All I know is it seems like there was kind of an alignment between our own team making their ratings and what the experts rated. So there's some reason to believe that this thing here is actually developing discrepancy. I could have put some other examples up, but that was maybe the easiest one to do. What's that? 5-minute mark. 5-minute warning. Uh-oh. Okay. Well, I'm almost done. That's good. And then the final stuff is really nothing new. Nothing different about what we would propose from what anybody else would propose, which is examining the efficacy of the change, measuring the theoretical mediators, back to those sorts of arrows, and examining whether the intervention changed the mediators, or the mechanisms, I should say, and whether that change was actually related to the change in behavior. If it is, then you really have something. What if it's not? Well, there's a lot of possibilities, but you'll be much better informed if you do these tests than if you don't. Here's some different designs, by the way, that are out there. And people debate what's the best way to do this with RCTs, using the MOST strategy, the SMART strategy. And I mentioned to you that big debate we had at the BMRC in terms of what stage of research do you do all of this. Those are all lively, interesting, and good debates. Let's just do something with it. Let's just get the theory involved and try to do something that's theoretically driven. This was a little, this isn't really accurate, I should say, right off the start, but it's kind of an interesting way of thinking about what might happen. You know, you might have your mechanism change, so you've measured your mechanism, and it did in fact change as you thought it would, and the behavior changed. So good theory, good intervention, it all worked well. But you might find that your mechanism changed, but the behavior didn't. Ouch. Well, assuming the mechanism change was no, that's what's wrong with this overhead, is it might be that you have a bad theory, that you can change this mechanism out the wazoo and it never really affects the behavior change. Or it might be that your intervention was actually too weak. So you got some kind of a mechanism change, but not enough to change the behavior. That would be a question to be thought about. What if the mechanisms don't change, but the behavior does? Well, you had a bad theory. Something good happened. You need to figure out what it was, but it didn't happen for the reasons you thought it would happen. And so the theory really didn't account for that very much. The mechanisms don't change and the outcome doesn't change. You could have had a bad intervention. You could have had a bad theory. It's the worst of all worlds. You didn't change the mechanisms that you targeted, and you didn't change the behavior that you were interested in. But the point being that you have to measure the mechanisms to know whether they made changes or not, and whether those changes had anything to do with the behavior that changed later on. If you don't, you won't know why your intervention worked or didn't work, and you'll be sort of left with maybe a successful intervention, but not really knowing what are the important pieces of that intervention. Here are the selected references that I said I would put up at the end if anybody's interested in following up. I went through some of this really fast and just kind of skipped over some of it. So if you're interested in those, but most importantly, we need to get to this slide, which is hopefully something you'll be doing in the next few days. At least I plan to be doing some of this in the next few days. All right, that's it. I think I'm out of time. I think you're probably out of time too, but I'm happy to take a question or two if anybody has them or wants to stick around. I can stick around and talk to people.